topic, that is OT, integral part of virtual care during coronavirus pandemic. It's such a important topic, which will be presented by Dr. Vijay Suple, who is the convener of this branch, and I'm sure he is such a experienced person, because I've been always hearing him in each and every conferences, and he's a very good speaker, and his contents are very good, and I feel it's a need of the day. This topic is very important and need of the day. So I feel he has chosen a right topic. So I'm sure you are going to learn a lot. And also, I want to tell you that I know many of you have registered for All India our OTCon 2021, which is normally we have every year the conference, but this time it is virtual. So we also have the pre-conference continuing occupational therapy education, this COTE, which is actually we have purposely kept it in the evening at 6:30, the same time. So you all are invited to attend, but those who have not registered for the conference can also can register it and attend it. And it is again because we have the international speakers. So the theme is breaking through the practice challenges. I think one of the, I don't know whether Dr. Vijay Suple knows him, he's from Canada, Dr. Atul Jaiswal, who is actually graduated from IPH Delhi, and then later on he did his PhD and and also the masters. He's a gold medalist. So he's going to speak on OT for concurrent visual and hearing impairments along with physical challenges. This other speaker also is not from Canada, but she's from US. Many people must be knowing her. She's Namrata Gram Prohit. She's assistant professor from the Department of OT, Jefferson College of Rehabilitation Science, Philadelphia University. So, and later on we'll have, this will be followed by a small panel discussion. Because before that, I want to say that she is going to speak on a computer adaptive testing in occupational therapy. This is an innovative assessment for tele-rehab. Again, I thought there is a need for the day, and because we have been now working on virtually and having assessment virtually, so this becomes very important aspect as far as the tele-rehab is concerned. So then we have the panel discussion on the skills and the challenges in OT practices, that is during the pandemic and before and even after the lockdown is over. So we have new people. We have actually this time included in the panel discussion the young therapists, because they are the one who have started the practice and what challenges they have got it and how they have been able to manage financially and even the OT practice point of view. So this will be, I'm sure should be a great, and I invite you all for that. So, and the problem time is not a problem, because we are going to have it at 6:30 in IST time, and maximum 2.5 hours to 3 hours. So this is also another invitation for all of you. And I'm sure today you will enjoy, and happy learning, and wish you all the best. Thank you.
Dr. Ghazala, would you like to introduce our speaker today?
Good day, all. It's my pleasure to introduce our esteemed speaker today, Dr. Vijay Suple, who many of us know very well. Vijay is the convener for the international chapter of the All India Occupational Therapist Association. He graduated from Nagpur School of Occupational Therapy and has done master's and doctorate degree. After moving to Canada, Vijay has worked in the field of workers' compensation as a staff occupational therapist, and currently works as a consultant in the community occupational therapist in the Closing the Gap Healthcare. Some of you will know Vijay from his contribution and presentations at the occupational therapy conferences in India. and he's been presenting on a regular basis since 2011 on a variety of topics. Vijay has presented at the Canadian conference as well as the WFOT conference in Sydney in Australia in 2006. I've had a pleasure of working together with Vijay since Nagpur OTCon in 2018, and his enthusiasm, passion, patience is admirable. In 2018, we sowed the seed of the international chapter, and Vijay has worked tirelessly to get us to where we are today. Let me hand you over to Vijay to speak to us about the very hot topic of the times, how occupational therapy is an integral part of the virtual care delivery during the coronavirus pandemic. Thank you. Over to you, Vijay.
Thanks, Ghazala. Thanks for a nice introduction. I thank everyone who is attending today's webinar, and I'm hopeful that it will add to your knowledge. And those who could not attend webinar for some personal reason, we will post the copy on our webpage, International Chapter AIOT. I would like to thank Dr. Jyotika Bidlani. She's the Dean of AICAIOTA for AIOTA, and she's constantly encouraging us, and we are going to work with us on the regular basis. Unfortunately, Dr. Srivastava couldn't come today, so he's busy with the conferences and meetings. So he's always supportive of our cause and supportive of our chapter. I thank all other board members, board of directors that working with me on international chapter, such as Harshvardhan from New Zealand, Dr. Sabari Subramaniam from Australia, Dr. Shruti Narkani from Dubai, Dr. Jayashree Chandramouli from Doha, and Dr. Karthik Mani from USA. Karthik is our all-around player of the team. He's a teacher, he's a researcher, he's a board of directors, and he manages all technical aspect of our conferences. Thanks, Karthik. Let me take a few minutes of your time before we start the discussion. This is the first webinar of year 2021, and next will be second week of April 21. Our chapter has created separate group of OT students from back home in India. It's called Student Wing International Chapter. At present, we have students from Parushi Jain from Ghaziabad, Purva Malhotra and Saima Nasim from Hamdard, New Delhi, Lakshita Jaya from Nirtar, Cuttack, Ria Bashit from Amity, Noida, Julia Banu and Liana Miriam from Meenakshi, Samin Afroz from Manipal, Sania Khanna from New Delhi, Ashvi Faria from Mumbai, and Purva Malhotra, Janki Parekh, and Vaishnavi Joshi from Nagpur. Our chapter has a logo now, and we thank Vaishnavi, Janki, Lakshita, Saima, and Samin for taking interest in that. Also, we are going to issue the certificate today, and thanks to Vaishnavi again for designing the certificate. We will be adding few more students on the list as the need is growing, and as we get some more recommended by the teachers. Our chapter is expanding educational and research activities in addition to sharing knowledge through webinars and mentorship. As a matter of fact, we have a meeting scheduled after this webinar. We are discussing about starting some research project for the undergraduate and postgraduate students, and there will be some monetary incentive grant for this project. So we are just hopeful that this will be helping our students to gain them some hands-on experience of the research. Now let's start our webinar discussion. Karthik, are you sharing?
Yes, sir. We could hear you and see your slides, but okay, we couldn't see you. If you want to, yeah, we could see you now. Thank you.
As you know, today's discussion is a topic of the discussion occupational therapy, integral part of virtual care during coronavirus pandemic. It's a very hot topic because we all are going through the coronavirus pandemic right now. And it was like last year in March it started. And there was a request from some of the teachers back home in India, and they wanted us to prepare for this topic. So we thought, well, let's start our new year with this topic. Let's get into the history of telehealth. Telehealth is not a new concept. It's uncommon to some professions, though, like occupational therapy. We never thought that we will be part of the telehealth. But the situation this year created that opportunity. It goes back to 1920 service in Australia. They started the Royal Flying Doctor. And 1920, that time, Australia was a British colony. So this was the first time that telehealth started. NASA, we all know, National Aeronautics and Space Administration, they accelerated the growth in the field of funding research to provide medical care to the astronaut in space and to provide in-flight medical care for commercial airlines, actually. As we all know, NASA has been in forefront of research, not limited to space only, but there's field of researchers were into medical field and all other sciences. And we all are benefited from their research activities. I can quote you two best examples that contributed to my practice, actually, as an OT, occupational therapist, and our practice, what everybody's practicing. We know the GPS, Global Positioning System, GPS, we use that to drive the car. A few of my clients are using small pendant around their neck or little small wristwatch on the wrist. We call them a lifeline or protect alert. What it does is, in case of a fall, that person has to push that little button and they get medical attention right away. The newer models in those lifeline, they have motion detectors also. So if the person falls on the ground, they don't have to press the button. The control center automatically will know that person has fallen on the ground. And they will call the 911 or they will call the family members to get the attention. So that model is based on the GPS actually. So we recommend that thing for a lot of my clients, especially people who are vulnerable to fall. Second most important research was temper foam, TEMPUR foam. The NASA used this temper foam as a liner, inside liner in the space shuttle. And some wheelchair manufacturers are using same format, not the same format, but different form of temper foam to manufacture the cushions. So you can get high density, medium density, low density temper foam. The bottom part of the cushion is high density, and the middle part is a medium density, and top part is soft density. So that my clients are benefited from that research that started by NASA a while ago. But 1960 to 2000, this period experienced slow growth in the field of telehealth because there was no need for that. Only they were using it for the isolated population, a rural population, which were like miles and miles and away from the mainland. The global growth has been steady but slow as the reimbursement rates were low for telehealth. So we will talk about this thing a little bit later, reimbursement rate. The reimbursement rate, like for our visit right now, we're like 30% than the actual visit rate. That's why the telehealth will become popular. And due to global scale of current COVID-19 pandemic, there is uncertainty around infection control and the treatment, and therefore the potential benefit of telehealth came into sharp focus in 2020. The healthcare delivery system model is also changing as we see the technology growth and the demand based on the demand also. most of the industrialized countries and even like Middle Eastern countries, they have a single tier system of healthcare delivery model. The government takes care of all the hospitals and the private care also. And countries like India, and they have a two-tier system. They are like the private hospitals, and the main one is the government hospital. That's like a major it's a free healthcare for everybody. But the private hospitals are like fee for service kind of service. So a healthcare delivery system is also changing because of coronavirus pandemic and the technology available for our use. This picture is pretty interesting picture. Thanks to my IT team for putting this picture together. In the black and white picture, you see steady, slow evolution of the telephone, telegraphs, wireless communication, internet, satellite communication, television, other advancement in the field of medicine. We know that telephone was, if there was no telephone, there won't be any telehealth actually. So telephone was invented by Graham Bell in 1875, 1876. This gentleman was born in Scotland, and he has a Canadian connection. He moved to Canada with his parents, of course, and then he worked in Canada, then he worked in USA. And he had a patent on that telephone. Actually, I was really amazed that they have a mechanism in place at that time, 1875, to put the patent on your invention. So that's amazing. Even like ISRO is, you see the picture of ISRO there. They are not behind. They are putting satellites in the sky. They are doing that for all for India themselves and all other countries. And actually, Indian educational or industrial revolution started right after 1947. Let's see the different use of tele. I was going through a lot of articles and journals, and I found this one interesting one. The telehealth, tele is used. This word is used for so many different reasons. Yeah, let's read that now. Telehealth. It's a use of electronic information and communication to support long distance clinical health that allows easier management. So we can call that we are part of telehealth. Telemedicine is a use of electronic media to diagnose and treat patient with the right intervention. As occupational therapists, we don't diagnose the patient, so this applies mainly for the physicians. Remote patient monitoring. It's a use of digital technology to collect medical and other form of health data from the patient. Actually, I have seen that a few of my clients, goes back about 10-15 years. The gentleman had some heart condition. He was carrying a little monitor with him, and he told me that there's a monitor station in Ottawa. They were monitoring all his vitals from that little piece of gadget they gave him. So it's being used before this thing also. Store and forward, electronic transmission of medical information, digital images, medical data. That's very common actually. I have few friends from India. They have a company in India, Hyderabad, and they have office in Canada and USA. So they transfer our electronic data, like a patient's information, patient chart, and they store that on like a huge computer. So that's, again, it's like a telecommunication. E-consultation, electronic exchange between the medical provider and their patients. That is, we are doing that also. M-health, medical and public health and practice supported by mobile devices. Teleeducation, the teaching and learning mediated by telehealth technologies where students and teachers are separated. That's what we're doing right now. So all this use of telephone devices that enhance learning, enhance treatment enhanced medical health. The future of the tele-rehabilitation. As we've seen, there are so many different names, the e-health, m-visit, telehealth. Developing a common nomenclature will be the next step. I think the professional bodies like AIOTA or American Association or Canadian OT Association, they would come up with some kind of standard wording or phrases that so we can all use the same words and same phrases. Digital technology is making it easy for the health professional to communicate with the patient. It certainly like added on to our work. A lot of reports and assessment reports and progress note we are storing electronically nowadays. So I spend almost like 60% of the time doing all that work on the computer and 40% time on one-on-one basis with the patient. Artificial intelligence is already existing in high-tech medical field, and it's become very common also. Like let's see, telemedication refers to treatment of various conditions without seeing patient in person. Healthcare providers may use telehealth platform like live video or audio, etc. Virtual care refers to broad term. It encompasses use of videos, audios, and instant messaging to communicate with patients remotely. It's a best use of term virtual care instead of telemedicine. It paints a more comprehensive picture of modern healthcare landscape, which includes more than just telemedicine. Actually, this document came from McMaster University in Canada. And we are using virtual widgets as a name for the widget. Like we don't say televisit, telemedicine. We just use a virtual widget, either done by telephone or video. Let's go back to March 11, 2020. Breaking of the coronavirus, this is March 11th, and actually started way before that. It started in December or January in Wuhan, as we know, in China. By the time it spread to all over the world, it was like middle of March. The WHO took a long time to declare corona as a pandemic. I don't know, they were not clear. Picture was very blurry, picture was very hazy, and they were not getting a whole lot of information from government of China actually. But ultimately, 11th of March 2020, they declared the pandemic. So this was the scenario in my office on April 13th. As COVID was declared as a pandemic and it was spreading across the globe. Our agency was preparing for a worst case scenario. And as probably you might remember, that Italy was hit really, really hard. And then it was spreading in US and Canada. So what happened that all clinical staff were in a panic mode. We were offered an option to take voluntary layoff for a period of time. So 70% of clinical staff, we decided to take a layoff. And there was a risk of shutting down whole community rehabilitation service in Ontario. So this was not limited only to our district. This was all over the Ontario. Voluntary layoff means you can go on unemployment and you get 60% of that. But at that time, the money was not even in our mind. We were not comfortable working in that kind of environment. 27th of April, The ministry agreed to increase the virtual visit rate from 30 to 80%. And there was a directive from the ministry. All clinical service providers were requested to resume work. We were designated as frontline were essential worker, and we didn't have any option. So we resumed. I was off for a couple of 2 weeks, and then we started back on 27th of April. At that point, ministry realized that community rehabilitation services, including OT services, were integral part of virtual care during coronavirus pandemic. And they didn't want to wait too long to take the decisions. And we were very glad that within 2 weeks, they called us back to work. And during that time, we received tremendous support from the ministry as well as the employer. There was no shortage of personal protection equipment. Healthcare providers were given choice to indulge in face-to-face visit or the virtual visit. An employer and College of Occupational Therapists, we call it COTO, that's a registration and monitoring body, OT practice monitoring body. They almost like gave us a option to choose whether we do virtual visit or a face-to-face visit. And during this period, we were briefed by the ministry, our office, and through webinars also. We got a lot of information about coronavirus. So our anxiety level was slowly like going down. Now, guidelines to practice telehealth. Now, this document was provided to us by College of Occupational Therapists of Ontario, COTO. But these guidelines were based on the work done by WFOT. Their document is dated 2014. American Psychological Association, 2013. American Occupational Therapy Association, 2012. And this document was revised in November 2017. If somebody wants the document, it's available. I can forward that to them. Just email me. Because this document is prepared by WFOT, I believe it applies to all the institutions and all the countries that are member of WFOT. Fortunately, like in this part of the world, everything is written on a piece of paper and in the form of the binder and policy. Maybe in some countries it's not that black and white, but the basic guidelines are the same, and it apply to whether you practice in India or New Zealand or USA. The first one is jurisdiction. What you should know and apply legislation, standard, and guidelines for telepractice services within the client's jurisdiction. So my client is based in Ontario, so I have to use the Ontario's guidelines. And jurisdiction for the provision of OT services is defined by the location where the clients reside. If the client is residing in Ontario, then the jurisdiction for the OT service is Ontario. If the client is in British Columbia, then the jurisdiction for the OT service would be BC. I cannot do virtual visit for the client who is living in British Columbia because that's not my jurisdiction. My license is limited for practice in Ontario, state of Ontario only. They have made the little provision now. I have to get the permission from OT college in British Columbia, and then I can do the virtual visit for the client, my client who is residing in BC. But that's very remote chance that I will have to do that. I was reading the National Commission for Allied and Health Professional Bill that is going to be passed in India. They call it Professional Bill 2020. Under the bill, each state will have a council, and they will maintain the state register. However, they did not mention about practice jurisdiction. So that means if somebody is registered in Maharashtra, probably he can practice in any state of India. I think that's what my understanding would be. But right now they don't have the council. They are just waiting for that. So hopefully that will be in effect in a couple of years. But all other countries, we just follow our own professional council, professional colleges guidelines. Risk management. What you should consider if the telepractice is the most appropriate means of providing occupational therapy services with consideration of the risk management and liability. OT engaged in telepractice are accountable and responsible for all the occupational therapy services provided to the clients. It's the same as face-to-face visit. And OT should ensure that client understand how the telepractice services will be organized and ensure clients know what to expect regarding the time and the duration of the appointment. In day-to-day OT practice, we always face some risk. And today in this scenario, it's coronavirus infection is the major risk, and that's why we are considering the telepractice. But otherwise also there's a risk when we see the client. In my practice, if I prescribe, say, a wrong cushion or something for the client, he's not getting proper support when he's sitting in the wheelchair, he's getting a skin breakdown. So there's always a risk for the client. So as a clinician, we have to identify the risk. In this coronavirus situation, we identify that there's a risk to the client that she might get infected. We want to analyze the risk and then address the risk and implement the plan and monitor and review the risk. So those are the 5 steps that we call it the risk management step. It's like a cycle. We all do that. We all experience in day-to-day life. Sometimes maybe the hand splint is not proper for the client. He may get like a musculoskeletal kind of injuries from the bad splint. And so we identify the factor, we correct the splint, and we implement and monitor the progress there. So that's day-to-day practice for the occupational therapy. Technology. OT must ensure that the technology used in telepractice is of sufficient quality, communicate effectively, provide safe occupational therapy interventions, and form an accurate professional opinion to make necessary healthcare decisions. Technology is available. I mean, we have cell phones available, we have computers available, we have video recorders available. Majority of my patients are older adults from 50 to 104 actually. And they are quite comfortable with the telephone devices. And we are using, maximum cases, we are using telephone as for our device for the virtual care. There were few occasions that I had to use a video camera. Those clients were fairly young clients and they were well versed with the technology. So it depends on the person that you are working with, and it's OT's preference also what technology you are going to use for virtual care. Confidentiality and privacy access. OTs using telepractice services must take reasonable measures to maintain confidentiality and protect personal health information. OT should inform their clients on the limit of privacy and confidentiality to be transparent about the risk of inadvertent disclosure while using the communication technology. These guidelines are standard for face-to-face as well as virtual visits. So in this scenario, if I am doing assessment, virtual assessment, I would have a special room so that nobody can hear the conversation that I'm having with the client. And I would keep that visit as private as I can. And when transmitting the client's information by electronic means, OT should maximize the confidentiality. We don't use Yahoo Mail or Gmail for transfer the client's data. We are strictly advised to use office email because there is always a 1% chance that it might get the information might get leaked. We are still preferring confidentiality may be enhanced by using encryption and password protection using a secure network, limiting use of personal health information as outlined by the College of Standards. But there is always a 1%, minus 0.1% chance that there might be some kind of transmission error and it might go to wrong hand or something like that. And we are still prefer the fax as the safest mode of transmitting information. If I have to communicate with another service provider or send some information to the vendor, we still use fax as a safe mode. Consent is a big part of our job, and it's most important thing of the OT practice. Prior to initiating telepractice services, OTs must obtain informed consent for occupational services, assessment, treatment, and consultation, as well as knowledgeable consent for the collection, use of disclosure of the personal health information. The first thing that my office did was they changed the consent form. We had a standard form for face-to-face visit, and we had a new form for the like a virtual visit. So it was changed right from day one, actually. But consent is two type of consent. Consent is like a written consent. The client allows you to collect the information, share that information, use that information to devise your treatment plan. The second consent would be like a oral consent. And it's also very important that you ask the client. We do that actually. I do that every day. We are used to so much. When I meet the client, I ask the client time to time, are you sure you want to walk for me? Are you strong enough to walk for me? So sometimes clients say, no, I'm tired. I just want to quit now. So that means the client withdrew the consent. She has given you the written consent, but for that moment, she withdrew that consent for that particular activity. So you just respect client's wish at that time. So it's a consent is like a written consent as well as verbal consent. And even when I am calling patient for my visit, I say, can I come? So they say, yeah, you can come. We are here. So you're asking for the permission. You're asking for the consent. You document all those things. Record keeping. That's another. We had 28 pages of document from the college how to keep the records. So OTs engaged in telepractice are required to maintain clients' records in accordance with the standards of record keeping. That's like a 28 pages of document. And they apply for the same apply for the face-to-face visit. So each paper, like when we do the initial assessment, the 5 pages assessment, each page has a client's name and ID, either like date of birth or another ID form. Each page is signed by the therapist. A progress note has a date. We keep track of all the phone call that we make to the client. It is noted on the progress notes. Consent form is one. That's one that needs, and the referral form. Like we have the referrals from the agency that's sending the patient. So we have to have their referrals also on the form. So this is like a pretty standard of record keeping, and these records are saved for 10 years actually. And you will be surprised. Yeah. I had a request for chart as well as 5 years old charts because there was some, I think, a case going in the court. Families dispute and dynamics were playing a role. So they wanted to check what was the OT's role there and when was she sane and things like that. So we get requests for the old records. So it's very important that we save those records. Luckily, my office keeps those records, so I'm not the custodian of the records. So records are kept by the office, so they are the custodian of the record. But I have to give the records when I'm discharging client. We have to give the file to the office, and we get their signature also, so that they receive the file. So record keeping has a lot of information, a lot of importance in this Western culture. Continuing and transferring care. If you are going to transfer that client to another therapist, the OT should be aware of the options of continuing care when providing telepractice services. I'm going backwards, sorry. If I'm going on a vacation, I have to tell my clients that somebody else will be seeing them. If possible, I introduce them with the client, so the client knows that I'm away. There is no discontinuation of the care. So that's clients. We're responsible to do that actually for the client. We cannot just discharge the client and leave him without occupational therapist. Professional boundary, that's another nice one. OTs must establish and maintain the professional boundaries. OTs always have the responsibility to maintain professional boundaries and be aware of warning signs for the boundary crossing. Warning sign may include excessive personal disclosure, development of personal relationship, and concession that are atypical of a client-therapist interaction. We have the relationship of trust with the client. I am the occupational therapist, and due to my position and my knowledge of my subject, client is vulnerable. I am at the position of the authority, and client is vulnerable. So we don't want to take any disadvantage of that situation. So those are the boundaries. We have to be really, really careful at each stage of when I'm involved in the occupational therapy practice. There should not be any power of imbalance between the client and the therapist. It applies to the virtual care also. I don't want to ask excessive questions about personal things. So that's about the virtual care. I can give so many examples about the professional boundaries. This is especially like in a Western culture. It happens in the hospitals, in the more acute care settings. Young patient, female patient, maybe male therapist, or male patient, female therapist. Sharing telephone, that's like a crossing the boundary. Going out with the patient for dinner or movie, that's a violation of the boundary. So you are already in trouble. And the college are the college are seriously looking into these aspects. Actually, right now, I just want to just give one example here. Actually, we have one OT, occupational therapy, female occupational therapy. She's facing charges now, because she was one of her patients, like she was in relationship with the patient. Actually, she was living with the patient while he was under her care. So that's a violation of the boundaries there. So you cannot patient. We have a relationship or trust with the client, and we don't want to break that trust of the client at any moment. Ethics. OTs are required to uphold the code of ethics and inform clients of their rights. We do that in the first visit when we get the consent form signed. Regardless of nature of practice or method of service delivery, code of ethics serves as a foundation of occupational therapy practice. In delivering telepractice, OT should implement the core value of respect and trust and apply the principle of collaboration, communication, client-centered practice, respect for autonomy, honesty, fairness, accountability, and transparency. Honesty, accountability, transparency, those are pretty there should not be any hidden agenda. And fairness is the patient. Accountability, you are responsible for anything goes wrong there. Honesty, So those are the ethics that we follow in everyday practice. It's either it's a face-to-face practice or virtual practice. Even just to give you another example, we're not supposed to take any gift from the clients. Not at all. Sometime one of my clients maybe say, Vijay, it's very hot outside, just have a bottle of water. So that's okay, I will take. But we don't accept any gift. Especially in a holiday season, you experience that more actually. The client, sharing gifts is very common in this culture. We can share we can accept the gift, but the college has put the limit there, like 10, not more than $10. So that's accessible from, it could be client or it could be the worker that you work with. So those are the ethics that we always follow for all kind of visits. Advertising. OT providing services by telepractice must understand and adhere to the advertising regulations that's given by the college. OTs are held in a position of esteem and trust by public because of our knowledge, because of our role as an occupational therapist. And we're not supposed to solicit for our business or anything like that. So advertising, you can put the advertisement in the newspaper or something, just like a occupational therapy services. You can use the title, Vijay Suple, registered OT, occupational therapist. That's acceptable, that's for everybody. But going from office to office and advertising, that's college doesn't kind of recommend that kind of advertisement. Fees and billing. These are for the OTs who are practicing on their own. They are expected to transparently communicate all fees associated with the telepractice. If there are fees associated with the telepractice services, OT should clearly communicate the information to client prior to commencing the service delivery. And by law, we are obliged to issue the receipt for the services we provided, for the money we accepted for that service. Fortunately, all my clients are serviced through local health integrated network, lean they call it in short, and this come to us through another referral source, so we don't have to charge the client. It's my service is covered by ultimately like the Ministry of Health. So, but occasionally, like I see some private clients also. So we are obliged to give them a receipt. They may claim that as a tax deduction or something like that, but that's their take on that. But we are supposed to give the receipt. Now let's see advantages of the virtual visits. Infection control, that's the main one, spread of photo main across the board actually. We're doing the virtual visit, even the physicians are doing virtual visit, specialists are doing virtual visit in this scenario because infection control and spread of COVID-19, that's one of the main one. It eliminates travel time also. That applies to a physician, I would say. It's a disadvantage for me because we get mileage when we go to patient's home. We get the mileage per kilometer, 45 cents or something like that per kilometer. So we are losing that because we're doing virtual visits. So that's a disadvantage for me actually. Yeah. It reduces accident rate actually because there are less people driving on the road. So you're less chances that you might get an accident. As a matter of fact, insurance company, they reduce the rates also because we're not driving as much now. So there's a little saving there. Convenience delivery of services in familiar environment. And again, like I do home care, so I go to the patient. My job is to go to the patient's home actually. Yeah. But other service providers, like in this scenario, like I was reading the article, like it said, there were even ENT specialists doing the virtual visits, and the surgeons were doing the virtual visits, like pre-op visits. So for this kind of safety, it's convenient for the client because they don't have to go to doctor's office, park the car, pay the parking fees, and spend the time. Rather, doctors calling them at home. So it's very, very convenient for the client. So those are the advantages of the virtual visit. More interaction with other healthcare providers and more collaborative care. That's what I felt that way actually. Yeah. Few of my colleagues, like physios, they were doing more face-to-face visits and less virtual visits. I was doing more virtual and less face-to-face. So in the scenario, then we used to interact with each other. Like I used to call them and share kind of what's the layout of the house, how is the client walking, that the mobility issues. So we were doing more interaction. We were doing more sharing of kind of clinical information with it. So that is advantage of the virtual visit. Like we got even like the nursing. I coordinated with a lot of nurses about my client. Yeah. So that is the positive thing about virtual visits. I'm going to ask you to see these pictures, and then I'm going to discuss about disadvantages of virtual visits. Okay, this is another picture of a client of mine, and I will show you this again. Drawbacks of the virtual visit. Breakdown in the relationship between occupational therapist and the patient. We are not seeing patient because we are just talking on the phone. So there's no bonding on the phone. It's somebody talking. He hasn't seen me. I haven't seen the client. So it doesn't get that rapport build up with the patient. Yeah. And that having a good rapport for any treatment, any intervention is nice for the client's recovery actually. So that's one big drawback is the breakdown in the relationship with the client and OT. Lack of healing touch. Maybe especially for physiotherapy, maybe physiotherapy do a lot of like hands-on kind of thing. But lack of healing touch, lack of healing presence actually I would call, because my clients are seniors, I mean way senior, like 90, 85, and they live alone in a home and they look forward to the OT visit or physio visit or nurse's visit. And so that's like a day for them. And they will put little mark on the calendar that Vijay is coming such and such time today. So that thing is missing from this virtual visits. And a lot of clients are kind of asking me actually, They said, can you come and make a face-to-face visit? So they are requesting face-to-face visits. So I said, okay, that's fine too, yeah. So that's another one disadvantage. Missing visual cues and body language. I'm going to show you that picture now. Let's talk about this one. Missing absent of the patient's home environment, which is critical for the home safety. I will talk about that a little bit later. I'm going to go back to the pictures. Okay. Missing. See, this is the face-to-face visit I did. Yeah? So I had to see the client. She's walking. I could look at these pictures, and she's walking. Her balance is not that great, so her both hands are a little outstretched. She's trying to balance herself. She's trying to keep not to fall, basically. So those things that was missing from virtual visit. So face-to-face visit, I get a chance to see her. I can say that, okay, now you are ready for the walker. The second picture that she's trying to use, get out of the chair, like supine to sideline position or supine to sitting position transfer. In this picture, she's not using the proper body mechanics. She's using her upper body more, and her legs are still on the bed. Actually, she should be trying those legs off the bed so that she can get some pull from the gravity. So that's the OT's job, and those things that you observe, like when you are asking them to demonstrate the transfer. So those visual cues are missing when I'm doing like virtual visits. This gentleman here, he had a fall history, and now see there, look at the picture now. I asked him to walk in the hall. He lives in an apartment. I asked him to walk for me in the hallway, and he had a fall close to that spot where he was standing. Look at the picture now. One hand is the cane, and second hand is on the wall. So what does that mean? That means that his dynamic balance is poor. Okay, so he's almost ready for the walker. So those kind of cues I get when I'm in the patient home, patient apartment, and I ask them to do things for me. So those cues are missing in the virtual visit. I can ask them, but client may not give me the correct picture. They say, "Oh, I am fine. I don't need a walker." So, but if I see him walking, then I can tell the client that, yeah, you are using wall, you are using the cane, so you are ready for the walker. So those things are missing in virtual visits. So the same lady, the walker. Now look at her expression, looks a little different than the previous one actually, because she feels secured with the walker. Both hands on the walker, and she's getting the support from the walker. Those things are missing in missing assessment of the patient's home actually. When we go to see patient at home environmental assessment is main part of my job actually. We want to make sure that client doesn't trip over on the rugs or loose cords or something like, or furniture or something like that, because clients are vulnerable for the fall. So in this virtual care, I don't get the chance to look at the bedroom, look at the living room, look at the laundry room, because I'm not there in the house. So the whole assessment, the home assessment is not even a valid assessment in my opinion. Same picture. This is functional mobility assessment. This is what the functional mobility assessment would be. Asking client to show the transfer and suggest some proper body mechanics when she is using that bed drill. There's another client that's a the wheelchair assessment. Excuse me. We cannot do wheelchair assessment without seeing the client. That's for sure. This lady we were just assessing her in the chair. That chair looks really tight for her. She's about 280 pounds. And I had to go to the retirement home. She's a resident of the retirement home. And so we did the trial on this chair. It was a little tight for her. And we had to get another like a couple of inches wider chair. So those kind of cues and those measurements, it's hardly impossible to do it virtually. This client, by the way, we were doing the assessment, so her daughter called me and she said, Vijay, can my mom get the power chair? So I said, well, we will consider her for the power chair. So then I had a talk with the nurses. I had a discussion with the supplier, her family members, and we ultimately decided to sort of go for the power chair. So this lady is getting the power chair now. See, this is the second picture. This was a little wider chair, I believe. Yeah. So she's sitting a little bit better than in this chair. So those wheelchair assessment, home assessment, transfer assessment, functional mobility assessment, those are the things that OT does in home care. And even like the kitchen assessment. So we cannot do those assessment virtually. So it has to be like face to face. And luckily, like clients, they are living independently. They live alone in the house. So they are isolated in a way. There is nobody else in the house. So just myself and the clients, and we still maintain the distance also in the home. So that's a drawback of virtual visits. Now let's see the summary. So relying solely on virtual assessment in the absence of valid clinical assessment tool and rigorous evaluation may do more harm than the good. So you just notice that assessment tools and the rigorous evaluation, we need to go through those batteries of assessment to do the good home assessment, and we cannot rely solely on the virtual visits. So what I do is if I had to given 3 visits, then I do 2 virtual, 1 face-to-face, or vice versa. And if I need a extra time or something, then we can request extra visit from the case manager, and they provide them. Current situation, they are very flexible now, so we don't have any problem getting extra visits for the assessment. The patient satisfaction with the virtual visits appear to be lower than face-to-face visits. This is debatable. I have read some studies actually, and I'm going to do little bit study maybe myself, and with the patient satisfaction, I'm going to do like a therapist satisfaction with virtual visits, and how we were seeing the virtual visits. So that will be, I'm kind of working on that now. During the pandemic, virtual care played a favorable role in healthcare delivery and will continue to do so. Yeah, that very true. Without virtual care, the whole home care would have been shut down, and then it would have been really chaotic. People would be going in the hospital, and hospitals were already overloaded with they wanted to keep the beds open for corona patients, and they were like critical care patients. So that pandemic and virtual care really work in a pandemic situation, and ministry was so nice actually. Now they pay 100% for the virtual visits, also is at par with the face-to-face visits. So my strategies are, and some of my colleagues as well, we are doing the mixed care of model, so virtual and face-to-face. And like I mentioned, maybe if I have 3 visits, I will do 1 face-to-face, 2 virtual, or vice versa. And some of the clients are very nervous about it, so they just say we want virtual visits, so that's fine also with us. So in other words, virtual visits is as important as the face-to-face visit, but we would prefer to go face-to-face more than the virtual. So that's conclusion. And I think we come to the end of the presentation now. I thank you everybody for attending this webinar, and I hope you get something out of it. Now we're going to hand over the mic to Karthik. Karthik, are you there?
Hello, sir. Yeah, thank you very much. Thank you very much for the wonderful presentation. I hope the attendees, definitely have benefited from it. Once again, if you didn't get a chance to put your name and email, please do so before you leave this webinar so that we can send you a PDF certificate. You must at least attended more than half of the webinar in order to receive a certificate. I've downloaded the attendees list periodically, so those who left the meeting, not even attending half the webinar may not receive the certificate. If you have any questions, please feel free to email me or Dr. Vijay Suple. Once again, thank you for your trust in the international chapter of IOTA and sparing your valuable time to attend this webinar. If you have any questions, please feel free to unmute yourself and ask it, or you may post your question in the chat box.
Harsh.
Hi, Karthik. I'll just give a vote of thanks to Vijay sir.
Sure. I thought like after he answers the question, we can do that. But you may go ahead and do it. Yeah.
Can I ask a quick question?
Sure.
Yes, go ahead.
Yeah. Congratulations, Vijay, for excellent presentation. I think it's very informative and very useful. I know Vijay for a long time. So my question is, you showed some pictures of the patients in the presentation. So do you have to take written consent from the patient? Because in US, it's very strictly prohibited because of the HIPAA violations. So I was just wondering what's the policy in Canada to share the pictures of
I take verbal consent. Sorry, I take verbal consent. Yeah.
Okay. Because in US, verbal consent does not stand. The patient can sue. So it's a policy that any patient photo that you are sharing has to be by written consent.
I ask consent and I explain the purpose of doing it actually. So I said, well, I might share with my colleagues in the conference, and is it okay? They said, that's fine. Yeah. So I make a note of that also in my progress notes. I will make somewhere a little note that I took the consent for that. Thank you. Thanks.
In Canada too, there is requirement for written consent for using any kind of media or pictures to be published anywhere. So that can come back to haunt if you don't have a written permission a year from now or 10 years from now.
Thank you very much for that. I'm going to speak with my office actually maybe and get a little more on that. Yeah. Okay. Thanks for the reminder. Yeah.
Thank you.
Thank you, Vice sir.
Ritika, do you have a question?
So, no, this is Sunita. Okay. I'm Sunita Kautarapu from TN Medical College, Nair Hospital, Mumbai. Sir, you spoke about registrations in India. I'm from Mumbai, so Maharashtra, we have a Maharashtra State OTPT Council, and it is a state council. So we are, all those who are registered can practice only in the state of Maharashtra.
Oh, okay.
So anyone who's passed out from Delhi comes and stays here in Mumbai has to first register with the Maharashtra State OTPT Council, then only you can practice in Maharashtra. So far, I have not come across any rules about telemedicine. So I don't know if the same rule will extend when you are practicing. Suppose I have a client in Delhi and I want to do tele-rehab. I don't know what rules will apply, but there is a Delhi council also, and I'm not registered there.
See, yeah,
So
this
just add to your notes.
Yeah, this tele-rehab practice, like a guidelines, that will apply to India also, because like India is a part of WA40, yeah, and it's for your council, like OTPT council, to create those guidelines, yeah, that will suit the Indian environment, and so that's their responsibility in a way. Yeah, they should have done that by now. Actually, we are almost in a year in the pandemic, yeah. So But somebody needs to remind them, maybe, I guess. Yeah.
Since I work in the professional regulation industry, I would like to chip in to respond to this question. Again, in the US, if a practitioner is licensed in one state and if they want to treat a patient who's resided in another state via tele-rehab, then the practitioner must also obtain the license in that other jurisdiction. So basically, in the US, they go with the location of the patient. So technically, I'm not sure, the regulations may be a little different. You have to check with the council officials, but I believe most likely, if you want to treat a patient in New Delhi and Delhi is regulated by the Delhi OTPT Council, then you must also obtain registration, from the Delhi OTPT Council. Hope that helps.
And there are quite a few states which don't have a council as yet.
Yeah. Yeah. See, that's what I mentioned.
Right now, only 2 states have implemented the registration requirements. I think some other states are in the process of doing so, but I think only Maharashtra and New Delhi have implemented. Correct me if I'm wrong.
Yeah. Only that Allied Health Professional Act, that's 2020, that's under Parliament now. They mentioned about the council for each state. Actually, it will be coming. It will be coming pretty soon. Yeah, I guess.
Yes, pretty soon.
They will have.
Let's hope.
Yeah. Okay, next.
Okay.
Thank you.
Any other questions? All right, Harsh, do you want to go ahead and render the vote of thanks?
Thank you, Vijay sir, for the informative talk. And the best thing I liked is that your style, you talk in a very calm and composed way with grace, and it has been a pleasure listening to you. And when you spoke, it was quite obvious that you were speaking based on your experience, and it was coming out in your presentation. And technology, it's like telehealth. COVID has given an opportunity for it to be accepted in healthcare. It was there forever, but for long it was there. But then there were so many excuses. The regulatory boards, the authorities, they were not prepared to safely allow that to happen. And it would have taken another 50 years maybe for that to happen. But once COVID comes, when a disruption comes, it brings a change. And I think this change is for good. And it's really, I was here in New Zealand, we did not get much of the impact of COVID. So I remember when you said for the first time when it hit and how you all felt in the office, and you gave an example when there was an option given to you guys to lay off voluntarily. So I remember that scary moment, because when it came to New Zealand, we were in similar situation. And then the whole journey you talked about, it's great. So thank you very much. And please keep inspiring us and keep doing the great thing that you have been doing. Thanks.
Thank you. Thanks, Harsha. I remember your presentation, and you mentioned that Corona is creating more opportunities. So that is true, actually. Yeah, we saw that in 2020. Now everybody Zoom meetings, and it becomes so common nowadays that somebody might come up with another technology. Actually, that's what I think. Easier than Zoom or other platforms. Like, yeah. And so it's an opportunity for all of us. Yeah. But thank you. Thanks, Harsh.
Wonderful. Thank you, Harsh. The recording of this webinar will also be available on our website, the international chapter of IOTA's website. If you have any other questions after this webinar, feel free to send them to Dr. Suple, and look forward to the emails from the international chapter regarding future webinars. And also, if you think of a good topic for a webinar, please feel free to send us an email so that we can find a suitable speaker and we can plug the topic in one of our webinars. Also, look for an email with a survey link to provide feedback regarding this webinar. We value your feedback as it helps us to improve our webinars. So thank you so much again for being here and spend your Saturday evening with us.
Thank you, everybody.
Sir, shall we conclude the meeting? Vijay, sir?
Yeah, we can conclude the meeting now, yeah.
All right, then. With that, let's conclude this webinar. Thank you. Have a good rest of the day, everyone. You know, most of you are from different time zones, so you have maybe more than half of the day available. So enjoy your day. Bye-bye.
Thank you.
Thank you.
So we are 10-15 minutes for our meeting, Karthik?
We have about 7 more minutes, sir.
No, for our meeting, like our chapters meeting, starting in 7 minutes?
Yeah.
Oh, okay. Okay. Thanks, Raisa. Oh, wow. Are we,
I'll excuse for a minute, then I'll be joining back.